it is my pleasure now to introduce our next speaker, Dr. Emmanuel Amoran. Dr. Amoran was born and raised in Nigeria. He earned his master's in public health at the Debrecen University in Hungary. He then completed his Medical Royal College exams in both Ireland and the UK before migrating to the US, where he completed his internal medicine residency at Pennsylvania Hospital in Philadelphia. Dr. Amoran is excited to be a member of the inaugural class of the Northeast Georgia Medical Center Cardiovascular Disease Fellowship Program. He believes the comprehensive training he will obtain under the mentorship of distinguished faculty and his passion for continuous knowledge in internal medicine will translate into high-quality care for his patients and the community as a whole. He is enjoying every aspect of cardiovascular training, and outside of medicine, he enjoys spending time with his family, playing and watching real football and American football. Please join me in welcoming Dr. Amoran.
Good morning. So I'm here today to present, to just talk about multimodality imaging and non-invasive cardiology. And I'm just going to give examples of some of the applications that we use. I have nothing to disclose today, and my objectives include understanding the role of multimodality imaging in modern cardiology, recognizing the key imaging modalities that we use every day, including echo, CMR, CCTA, cardiac CTs, nuclear, and their strength limitation, and how we apply multimodality imaging in complex cases. And then we evaluate the complementary nature of imaging technique in clinical decision-making. So in the last 20 to 30 years, there's been significant advancement in multimodality imaging in understanding and management of cardiovascular disease. And this has impacted the way we evaluate and assess coronary artery disease, structural disease, arrhythmias, heart failure. And also, this has benefited a lot of special population, including evaluation of cardiac amyloidosis, women with microvascular dysfunction, high-risk individual with severe valvular heart disease. And now we have AI machine learning application in cardiac imaging that has identified previously unrecognized pattern of disease. So now I'm just going to talk about some of the, I'm going to give examples of some of the multimodality imaging tools we use and the applications. So I'm going to talk about echo and specifically global longitudinal strain. GLS is a quantitative measure of left ventricular myocardial deformation, which is assessed using speckle tracking echocardiography. It reflects the percentage of myocardial fiber shortening in the longitudinal axis during systole. A more negative value indicates better contractility. And why do we use this? We use it when we apply GLS, we're able to detect subclinical LV dysfunction. It's useful in risk stratification in some cardiomyopathies, including amyloidosis. It can be a prognostic tool in valvular heart disease. GLS, specifically LS strain, is actually an additional tool now that can be used in risk stratification in heart failure with preserved ejection fraction. And sometimes, we could see subtle regional wall motion abnormality just based on GLS. And then you can use it in right-sided disease, including pulmonary hypertension, congenital heart disease. And also, we can use it as surveillance tools in the treatment of some of the cardiomyopathy. Now, I'm just going to give some examples of what they look like. Over here, this is what the normal GLS should look like. You have the segmental strain curve, which you can see the homogeneous contraction, and then you have the bullseyes. On the next slide, we have what we call the left, sorry. Over here, we have the left strain, which is a feature used in in further restratification in people with heart failure with preserved ejection fraction. And apparently this is actually superior to use more than using the left atrial volume. On this slide, we see a different pathological pattern of GLS. This is the typical apical sparing pattern that we see in amyloid. We can see that there's global reduction in GLS around, and on the top images, we have two disease patterns. One is a patient with severe hypertension, and the other one is patient with hypertrophic cardiomyopathy. We see reduction in GLS, specifically in the area of hypertrophy in both patterns. So again, applying GLS when we do transthoracic echo or even transthoracic echo can give us additional information in restratifying patients. In these images, I have 3 different patients with amyloid cardiomyopathy. We have the echo, we have the cardiac MRI, and we have the GLS. You can see that they all have different pattern of the GLS. Again, this will give us additional information comparing the lower patient who has a normal GLS compared to the upper patient who has severe reduction in GLS. We can tell that this patient has a poorer prognosis compared to this one, but they all have cardiac amyloid. And this, on this side, we have a patient that had a 65-year-old patient that has breast cancer, and she was started on chemo. This is a pre-chemo GLS pattern, which was normal. And 3 months after, they did a transthoracic echo with GLS, and we could see there's a reduction. A 15% reduction is a significant reduction in GLS. So based on this, it's informed the oncologist and the cardiologist that, hey, we need to start cardioprotective medication on this patient. So it's also important that when we're doing this to use the same vendor, because every company have different numbers when it comes to a significant reduction in GLS. Over here, we also have 3 different patients, with severe aortic stenosis. You can see the velocities are above 4, and the question here is, and they are all, the question here is, when do you intervene? GLS can be a tool to use to see, okay, which of this patient, especially if we claim they're asymptomatic, which of this patient do you think you need to intervene faster? Now, compare the patient on top to the patient on the bottom. They all have severe aortic stenosis, but looking at the GLS strain pattern, obviously this patient has a worse pattern. There's a significant reduction. Now, the question now is there also some superimposed infiltrative disease? You know, when you see this pattern, maybe we should investigate that further. All right, that's all about GLS. Now, I also want to talk about 3D echo. 3D echo is a valuable tool in cardiology, offering more than accurate, comprehensive view of the heart compared to traditional 2D. 3D echo has a large amount of applications right now. It's used in valvular heart disease, assessment of valve morphology. We use it a lot to assess mitral regurgitation mechanisms. We use it in assessment of left ventricular function, volume, as used in congenital heart disease, visualization of the complex anatomy and septal defect. We use it also in assessment of left atrial appendage, closure planning. We use it a lot in a lot of interventional cardiology procedures, and also differentiation of tumors versus thrombus. So I'm just going to highlight some examples of application of 3D echo. On this slide, we have a patient that came in with MR. This is a 3D echo. We could see that there's malcoaptation of the anterior and the posterior leaflet, and color 3D, you could see the mechanism of the MR. Over here, this is a patient that has mitral stenosis. Using multiplanar reformation technique, we could actually measure the mitral valve orifice area. In this case, the mitral valve orifice area is 1.34, which again demonstrates severe mitral stenosis. And this is an example of a patient that has a mitral valve flare leaflet. You could see the leaflet tip on 3D echo, and this can definitely give you additional information on what to intervene, how to intervene, what's going on. And this is an example of a patient that has a mitral valve prolapse. This is just a 3D echo just showing the aortic valve, and we have the trans-illumination and transparency rendering package software, which you just, again, you can see that it's just, it is a normal aortic valve. I thought it was nice, that's why I added it. And this is a patient that had tricuspid regurgitation. We can see also the malcoaptation of the leaflet. And over here, again, this is just a trans-illumination transparency software where you can see how nice the left atrial appendage looks. And as I said earlier, 3D echo actually provide a full volume imaging which eliminates this geometric assumption of 2D echo. Thereby, the volume and the EF that we get is as accurate as cardiac MRI. So hopefully, I believe we use a lot of 3D echo, and hopefully moving forward, we're gonna be using it more. And these are some of the interventional cardiology procedures where we use 3D echo. We have right here, this image is just showing transeptal puncture. We have ASD closure device. We have valvuloplasty, left atrial appendage closure, mitral clip, and this is a valve implantation. Just generic examples of the applications. Now let's talk about CT. So cardiac CT has become a comprehensive imaging modality which offers both anatomical and functional information to guide patient management. Right now, there are various applications of cardiac CT, including coronary artery assessment, structure, evaluation and assessment of structural disease, prospective valve evaluation of the aorta, aortic pathologies, and cardiac masses. So I'm just gonna, again, give examples of some of the applications, some cases. So in this, we have a 69 years old coming in with a history of hypertension, dyslipidemia, and carotid artery disease. Patient had abnormal EKG, abnormal ECG, exercise ECG was not diagnosed because of reduced functional capacity. So the patient got a CCTA. Right here, on the CCTA, we have moderate disease in the left, in the LAD, proximal LAD. So this was sent for CT-FFR. After that, CT-FFR came back as 0.70. Now, normal is above 0.8. So therefore, patient was sent for coronary angiogram, got stented. This is one of the major use of cardiac CT, and it's a class 1 indication in people with chest pain with intermediate to high risk. So there is an ongoing study, clinical trial, which is called the Precise Procedure and PCI Plan, P4. I believe they're still recruiting. It's a multi-center randomized study with a non-inferiority design comparing clinical outcomes between CT-guided PCI strategy versus IVUS-guided PCI strategy. Their primary endpoint includes cardiac death, target vessel MI, ischemic-driven target vessel revascularization after 12-month follow-up. The question is, how does CT guide us with PCI? What are the questions that we're trying to answer? So the potential questions we can answer with a CT when we have the right package includes, what type of lesion are we dealing with? Is it a complex lesion or a simple lesion? We can also answer the type of guide catheter to use. We can, on CT, we could see the position of the ostium of either the right coronary artery or the left coronary artery. If it's anterior, if the, what do you call it? If it's an anomalous coronaries or not. We can, depending on, again, the lesion type, we can decide, we can have the information. Do we need additional preparation? Does it need atherectomy? Do we need any additional stuff to perform this? Also, we can make a decision on the size of the stent. Do we need a long stent? Because based on CT, we have information on the plaques. Also, again, we can have information of side branches. In the event we need to gel any of the side branches, what area of myocardium is at risk. So, and we can do a simulation to get the FFR after stenting to see what the result will be. So there are vast majority, this software, I don't think we do it yet, but this is something that I found interesting because also they use this to make decision on bypass. So maybe over time, eventually, we're gonna be doing CT guided PCI and bypass planning. And this is just an example of a patient that had TAVR implantation a couple of years ago, and patient did a follow-up transthoracic echo. There was elevated gradient, and there was suspicion of hypoattenuation lesion. So the patient was sent for a CT. You can see some hypoattenuation lesion over here. And when I play the images, you can see that the leaflet looks thickened and restricted. And this will give you additional information that there's a problem here, and this patient was started on anticoagulation with a follow-up plan of doing transthoracic echo. A bit about cardiac MRI. So cardiac MRI has become the gold standard for evaluating cardiac function, volume, scarring, and also is unique in its comprehensive tissue characterization, including assessment of myocardial edema, myocardial perfusion, diffuse fibrosis, and also has become an indispensable tool in evaluation of congenital heart disease, heart failure, cardiac masses, pericardial disease, and coronary artery disease. Again, these are some, applications overall that we use. We use cardiac MRI for a lot of things. And these are, again, some of the examples, if you want to understand the cardiac function, evaluation of regurgitation. We can also do stress MRI if we're worried about ischemia, and tissue characterization for patients with amyloidosis, myocarditis, and also it can be used for coronary imaging and cardiac masses. Just some examples of its applications. Before I go, so we have various sequences in cardiac MRI. This is one of the sequences which is called the dark blood sequence. In this sequence, we're able to evaluate cardiac and vascular anatomy, tissue characterization, including edema and infiltrative disease. And we also have the bright blood sequence, which is very useful also in evaluation of cardiac anatomy and also cardiac function. Cardiac MRI also can demonstrate, we can evaluate congenital heart disease, aortic dissection, aortitis, pulmonary vascular disease, including pulmonary stenosis, And we have the late gadolinium enhancement sequence where we can evaluate for fibrosis, infarct. And over here, this is just an example of a patient that has subendocardial LG enhancement or late gadolinium enhancement, which is suggestive of ischemic disease or infarct. Meanwhile, over here, I have a patient that has patchy myocardial enhancement, which is suggestive of, in this particular case, because of the other pattern of HCM. Oops. So this is a 24 years old that came in with chest pain and COVID. On cardiac MRI, we can see late gadolinium enhancement in the mid-myocardium and sub-epicardial area. And then when we do tissue characterization with some of the parametric techniques, including T2-weighted imaging, we could also see diffuse anterior lateral enhancement. Now, this pattern is suggestive of myocarditis, especially if it does not meet a vascular distribution. And this is an example of a 64 years old patient that was seen with left atrial mass on echo, and they did a cardiac MRI, and using the different sequences, we were able to tell the difference between a thrombus and a myxoma or other masses. And in this case, using these following sequences, we could tell that this is a thrombus. And just a brief talk about nuclear imaging. Yeah, so nuclear imaging is valuable for evaluation of cardiovascular disease and allowing non-invasive evaluation of cardiac physiology and function. And it provides complementary information to that already with anatomical technique. The common application of nuclear imaging includes ischemic heart evaluation, evaluation for cardiac inflammation, infiltrative disorder, masses, infection, and quantification of microvascular disease, ejection fraction, etc. So I have an example of a 76 years old male coming in with medical history of hypertension, dyslipidemia, coming in with chest pain. Patient was sent for PET CT, and on the PET CT there is a fixed perfusion defect in the apex. Apart from that, the MPI was normal. The gated images were also normal in this case. So, on the CT, on the other hand, we have diffuse disease, diffuse coronary calcification. And then on the MBFR, the patient has diffuse reduction in MBFR in the myocardial blood flow, which in this case was 1.7 with reduction in all territory. So this was concerning, so patient was sent for coronary angiogram, and this showed 80% left main with post-stenotic dilation into the origin of the LAD. Ramus was 70%, and also the RC had catheter dapnine, suggesting about 90% stenosis in the ostium. So this patient was sent for bypass. Now, why did I present this case? Because this highlights the importance of checking myocardial blood flow. And what is that? So myocardial blood flow assesses the amount of flow through coronary vessel over time. Basically, it's the ratio of stress flow over the rest flow, and it integrates the effect of both focal and diffuse epicardial microvascular disease. And why is this useful? We can use it to confirm confirmation of perfusion assessment. If there's a discrepancy between the perfusion and perfusion CT and also the myocardial blood flow, this will give us information and prognostic information. We can use it to assess for microvascular disease, and there are other important use of this. Now, just another use of nuclear cardiology, we have a 41 years old coming in with history of pulmonary sarcoid, not on treatment, coming in with presyncope, found to have a complete heart block. Echo showed EF of 49 with septal dyskinesia. Patient was claustrophobic, so they couldn't do an MRI. Then we decided to do an FDG scan. On this, we have the MPI, and then we have the FTG. Over here, in this case, we could see FDG uptake in the basal septum and the inferior wall, which is consistent with cardiac active sarcoid. Again, as I mentioned earlier, nuclear cardiology, we use it in evaluation of amyloid, sarcoid, inflammation, viability. So it's just another example of its application. And this is the clinical scenario in which PET may be useful in patients with cardiac sarcoid. If a patient already has extracardiac sarcoid or abnormal screening for cardiac sarcoid, it's an indication to do this. A patient less than 60 years old with unexplained new significant conduction disease, patient with idiopathic sustained VT, and already patient known to have cardiac sarcoid on treatment, we can use it as a surveillance tool. So I just wanted to, again, talk about 3 quick cases that we saw in this hospital where we used the combination of multimodality images to kind of manage the patient. So the first is a 76 years old female coming in with intermittent dizziness, unsteady gait, visual changes, medical history of hypertension, diabetic, chronic kidney disease, and CVA. Patient, obviously, the first step is to get a transthoracic echo. I don't know if you guys can see it clearly, but there is a mass in the right atrium. So patient was sent for cardiac MRI. And on the cardiac MRI, they did see a mass in the right atrium, which was extending into the IVC. But the pattern of the mass was also concerning for malignancy. So the differential diagnosis at that stage was this is either a thrombus, a mass, or a metastatic disease. Patient was sent for CT to rule out renal cell carcinoma, which was negative. And patient eventually was sent for TEE to evaluate to see if this potentially a myxoma or something else. Because again, none of the information that was done was clear on what is this. So on TEE, we could see a big mass in the left, in the right atrium, which was actually extending to the right ventricle. And according to the report, they could see a stalk attached to the septum, which is classic for myxoma. Patient was sent to the OR, and this was excised, and histopathology came back as myxoma. This is another case of a patient that came in with a 55 years old male that came in with heart failure symptoms, history of monomorphic VT, was in cardiogenic shock. He has a history of heart failure with reduced EF, mitral valve repair, hypertension, paroxysmal AFib, and obstructive sleep apnea. So in this case, patient came in, they did a transthoracic echo. This is the left ventricle, the left atrium. Over here, it looks like mild MR. But there was significant suspicion that this is more than mild. So they did another limited echo. Again, this looks like multiple jets with possible moderate MR. But because patient came in with heart failure symptoms and VT after he was stabilized, he was sent for MRI looking for scarring, any etiology for potential VT. And also, we could use MRI to evaluate for we can quantify the MR. This came back as moderate MR, and there was no evidence of scarring on CT, on cardiac MRI. A patient was sent for coronary angiography again, based on his presentation, which was normal. Eventually, a patient was sent for TEE, and this definitely shows severe MR. So the point of this case is that, when you have high index of suspicion for a particular pathology, Don't just stop there. Move forward and just do additional investigation, which will help your patient. And this patient eventually was sent to the structural clinic. And the last case is just a 21-year-old female with a history of IBD coming in with chest pain. Patient on arrival, EKG was sinus tachy, trope was 2700, anti-proBNP was 3800. The initial echo, looks like LVH with moderate-sized pericardial effusion. Patient was sent for MRI, which showed diffuse LG enhancement, elevated T2 imaging. Basically, the pattern was concerning for amyloid, which is strange in this particular presentation, given the young age, 3 days of symptoms. Eventually, amyloid studies, including electrophoresis with immunofixation staining, was sent, and they all came back negative. Patient eventually got a PYP scan, which was also negative. So over here, this is the patient's PYP scan, and I just give an example of what a positive PYP scan will look like. So eventually, the patient was treated as myopericarditis, and she's doing well. So in conclusion, multimodality imaging is the cornerstone of modern non-invasive cardiology, allowing for comprehensive assessment of cardiac structure, function, and pathophysiology. The choice of imaging modality should be guided by the clinical question, the patient characteristics, and the expertise in every institution. And, multimodality imaging goes beyond anatomy. It provides functional, hemodynamic, and molecular insight. So I encourage my colleagues to learn more about multimodality imaging because, again, I believe this will help in optimizing patients' care.
Thank you so much. Excellent talk.